Hi, my name is Alex Parsi. I'm an endodontist in Los Angeles. I started out at UCLA, got my dental degree, had a year of certificate programming and general practice residency. And then I went to Albert Einstein Medical Center for 2 years for my endodontic training in surgical and microsurgical endodontics. Shortly thereafter, I returned to Los Angeles and set up my practice for 3 years now. Started in '06 and here we are today. I think the areas in endodontics that really are going to benefit from three-dimensional imaging preliminarily are diagnosis. There's so many cases and so often that we don't see the whole picture based on a two-dimensional image, or maybe it's something that's emergent or something that's chronic and we don't necessarily see those fine points, and we go ahead and take a three-dimensional image, for example a fracture maybe, or a perioendo lesion, things of that nature, where having another tool set where you have another set of information coming in, you can make a more comprehensive decision on your, not only your diagnosis, but further on the line, your treatment planning. I didn't need something that was a complete three-dimensional solution. For me, a focal 3D was really what I needed. I needed something that was, you know, and on the one hand, good to the patient in the sense that we got the information that I needed that was appropriate for each case. And how often do we do multiple root canals? We don't. We usually are diagnosing one, maybe two root canals. So a focal system really fit that profile for me. And you know, it's funny, the most important thing is quality, the image quality. And I looked at so many different ones, and when I came back to the SUNI CDA kiosk, I really looked at the system once again, and I kind of, you know, put the images side by side, and not only was it the best image quality, but for the price it was just right on for me. So it made it very affordable for an endodontic practice, especially mine, a small startup, to afford this type of technology and to give and bestow this type of technology upon my patients. For an endodontic practice, a focal field of view is ideal because you're really only diagnosing one or maybe two teeth. And it has an added benefit for me. It helps me sleep easy at night because I don't have a large data set to diagnose and worry about. I only want to worry about the area or the teeth that are really important to me. And if we have a comprehensive type of CT study, then all that other data set is also something that potentially can become a liability in the future. Since I've got the 3D and since I have opened up my capabilities in my office, a lot of my referring dentists have taken note. It brings a certain bit of credibility to the clinician, okay? When you can go ahead and use that other tool and diagnose something that may have been hard to diagnose originally, okay? Resorption cases are the first thing that I think about. Maybe endoperio cases, fracture cases. Some of them are resolved, some of them are not. A lot of cases are unrestorable. I personally, in my practice, I remove these teeth, augment them with bone, and then I get them over into an implant at some point. So it really is comprehensive. It gives me another hat to wear in my practice where I can say, you know what, if we can't do it for you in an endodontic fashion, we can certainly do it by extracting the tooth and putting in an implant. We have tooth number 29 here, and this was a non-probable case, meaning that when I placed a perioprobe here, I could not get into this pocket, which begged the question, can I treat this and save this tooth? I don't have recalls on this case as of yet, but if you notice, we have a large, sizable lesion. There's definitely breakdown of bone on almost reminiscent of a J-type lesion, which is a good indication or pathognomonic for a fracture, but we could not probe it. So the patient is older and she does not want to move into implants. As we all know, that takes anywhere from 6 months to a year just to restore and get some function. And endodontics is quick, and within a few days you're functioning on your tooth. So she wanted to keep the tooth, and I decided that I wanted to do three-dimensional imaging to verify some things for myself and to give the patient a very educated and comprehensive success-failure ratio. So I did that, and we're going to take a look at that in just a second here. So if we go ahead and look at our axial cut, we can move our cursor to any point that we want, and here we're going to move right to the middle of the infection. And if we go down here to get our coronal section, we can see something very remarkable. We can see a large lesion, but we never knew that it extended so far down. In fact, it's so far down that if I go ahead and place this right there, that's our nerve in the green, and you can see the proximity of the nerve to the infection. So that's the first thing that we'd want to note. But if we go ahead and now go back to our sagittal, we kind of see our nerve here, and again we can outline our nerve canal here. And see the breadth of the infection. It doesn't break through in these few slices, but right over here it looks like there's no crestal bone. Again, this case was not probable, so we went ahead and treated the case, and we have yet to get a recall. It's only been done about 2 months now. But I am confident that with this imaging, it gave me the ability to, 1, diagnose, 2, treatment plan it, and give the patient a really incredible show where I could describe everything for her concerning her condition. And she was really very confident in me after I showed her this technology. It was a win-win for everyone. Okay, our second case is a young lady that presents with no pain and previous root canal treatment. This was the initial root canal treatment, and a very large periapical radiolucency, which initially appears to be a cyst, but we can't make that diagnosis radiographically. What was very interesting about this case to me was that, you know, when you see this type of lucency that's so dark, we automatically assume that it's a through-and-through lesion. And in fact, it was on the palatal, but not on the facial, as we'll see in just a second. So we retreated the case, and here's the final case. And we know that this was before, and this is after. And we know that it's not going to heal, so we're going to have to intervene here surgically. And the young lady is slated to undergo apicoectomy, and we're going to send this tissue in for biopsy to confirm or get our differential diagnosis, cyst, granuloma, whatnot. If we look at the VR image, which is actually one of my favorite images to start to show my patients what actually is going on, we can see something really ideal here. If you notice right up here, this is the breadth of this cyst. Not only is it expansive mesially and distally, but it's expansive apically. And in this cone beam image, which is kind of gives you a great idea of what this technology is capable of, we see a large defect right above this tooth, and we see the breadth of it. Again, this is going to be a very large cyst-like tissue that we're going to have to eventually remove. Again, we see the sinus here. It is almost expanded to the anterior wall of the sinus. So let's go ahead and take a look at another view here. What you can appreciate from this view is that we have our wall here. You can see that thin line. So the facial is intact, but look at the breadth of this infection. Again, palatal is completely gone, and it extends all the way up. And then we knew that from our virtual reality image, of course. So how does this affect my treatment planning, my case acceptance? Certainly when a patient sees something like this, they eventually want to have that treatment done. But treatment planning, it tells me that, well, you know, we're up against a very large cyst. We know we need to submit this for biopsy, which we always do regardless. It tells us how much bone that we need to augment. And now we know, because of the broken palatal aspect of bone, we know we have to augment and place a membrane in order to get healing in this area. About a 70-year-old woman came to me complaining of pain on the left quadrant. We didn't know exactly what it was. You know, obviously we have this tooth that was treated a long time ago with a post and some recurrent decay around the crown. So we decided to treat this one first. We also knew that she had a probing depth on tooth number 14 on the palatal, but we didn't know whether that was a fracture. It couldn't be visualized intraorally or microscopically at the beginning. So our case started with the retreatment of tooth number 13. We went ahead and did that, filled the case up to where it was supposed to be, large diameter instrumentation with antibiotics and so forth. And then we started to address number 14. And that's really where I want to bring your attention to. Number 14 seems like it was done well. The palatal seems a bit underfilled or non-filled, we don't know. But after looking into it a little further, we went ahead and medicated the case. And we found out that the palatal did, in fact, after medication, depict a fracture, a vertical fracture. And this is the palatal root right here, and you can see a little bit of a line showing that there is bone loss over there at that angle. We decided that we were going to, at that point, schedule her for implant. Again, a 7-year-old woman, she didn't want to really go into implant. It's a long-term process, 6 to 8 months maybe, and after bone augmentation and so forth, and she wanted something immediate. I think the phrase that she used is, you know, at my age I could be dead, you know, in a year or two, and what am I going to do with an implant at that point? So we went ahead and offered her something that was offered a little while ago before implants came along, which was root resection. So we retreated the case. You can see this was before and this is after, and they're much thicker and more pronounced filling points. And then this is actually, I cheated and I went ahead. This is actually after resection of the palatal root. So we have the palatal root here. It extends all the way up here. That's direct post-op. And this is after the surgery for removing the palatal root. Now, how did we arrive at diagnosing and treatment planning removal of the palatal root? Well, it was patient concern, but also, again, I used three-dimensional imaging to create a great deal of patient acceptance so she could be confident that we could do this for her, and why the palatal root at this point could not benefit her any further, either lose the root or go ahead and extract the tooth and place an implant. And this is the case. Again, I'd like to start off with the three-dimensional, and you could see all three roots, distal, the mesial, and the palatal, right there in that image. And again, I want to bring the point that this is a focal CT, which gives me exactly what I need. 3 teeth, maybe 4. And I don't irradiate the patient more than I need to. So you'll see right here that this is, in fact, the palatal root, the fracture, although that may not be able to be as clearly seen, the fracture. But what we see, which is very unique here, is that the sinus, we can see these bony projections as if the sinus was either expanded or broken. And this was prior to us even treatment planning for root resection. We wanted to do an implant, and we wanted to know how much bone we had to deal with and whether we could do an implant and what our measurements were. But it gave me an incredible view into her particular case and what were the limitations. For example, in this case, I would have, removing that root, had I not known this, if I pressed apically, I may have pushed the root into the sinus. Things of that nature. In our two-dimensional image, this was not apparent whatsoever. I mean, you did not see that. But in our three-dimensional data set, we can see that this is uncanny and really it's a wonderful tool to have to understand the case better.